Okay, students, so this is the recording for the lecture for week 8, chapters 13, 14, and chapter 40. I wanted to remind you all that there's no exam this weekend. It's going to be next weekend, including next week's lecture. There's no lab class on Friday, remember, because you have your Saturday deal with Anne. So you can get the final, if you don't know, the final where and when and stuff from Anne on Thursday. And then the other last thing is some students have emailed me about their grade and Foundations Lab. There's a problem with some of the grades that are showing up, and Moodle is working on that. They can't figure out what's going on, so you'll see that your grade hasn't changed. But I just don't want you to worry because lab is pass-fail. I record those grades for your post-tests just to provide evidence of your pass-fail along with your sign-offs. So I know that those grades are not correct, and so don't worry, you will pass the course. So it's just basically a technicality that will not affect you at all. Okay, so we'll get it fixed, or Moodle will get it fixed when they can figure out what's going on. So anyways, let's get on with the lecture. They're going to be quick. So I do want you to, if there's any information in these these PowerPoints that you have questions on, please write those questions down and follow up with me next week. I will be back in town next week. Okay? So evidence-based practice and nursing research. Also, this reminds me, so your oral presentation that was scheduled for this Friday on your evidence-based project will be the following Friday, okay? I don't know what that date is right now off my head, so no worries about that, okay? Here are your learning outcomes for the chapter. Please review these so that you know what is expected for your learning for this content. So I don't go over a whole lot in this about nursing research, except for the important things that will be applying to your ASN practice. However, do not neglect this chapter and understanding the different kinds of research and how it's conducted, because you do take the same NCLEX exam that BSN students take, and this information may be on there. However, I don't feel there'll be a lot about nursing research, but there could be some questions. So anyways, so nursing research, it does provide a scientific basis for our practice. And nurses do conduct research, and they do contribute to our the theories of the nursing care and evidence-based practice. So what are, according to the evidence, what is the best practice we should be providing for our patients? And you will hear a lot of people say, there are a lot of people, like, for instance, I'm going to use the example of IM injections. So I'm sure you students have learned about IM injections in Pharm Lab. Back in the day, and for many, 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 many years in nursing practice, we would give an IM injection and we would aspirate to make sure that we weren't in a vein, and then we would inject our medication. And evidence-based practice has told us, the research that has been conducted on IM injections has told us that that is not best practice. There are specific sites that we give IM injections, and if we use those specific sites, then our chances are nil to none of injecting a vein or an artery or, our blood vessels. So evidence-based practice is telling us not to aspirate. that it actually causes more pain to aspirate, and it does not, it does not prove that it does prove that we're not in a vein. But however, if we're doing correct technique, we're not in a vein or an artery, okay? So it's more traumatic for the patient. It makes the injection last longer, and it's not best practice. But you will see many nurses still aspirating. And that's just one example of how we've done things for so long in nursing, and a lot of times it's hard to change people's practice, especially when they don't see any harm in it. But but we as new nurses are going to do what the evidence tells us. Okay, so the American Nurses Association does recommend standards for how nurses participate in research. Every nurse that is practicing today needs to participate in research. That does not mean that they need to be in a lab blowing up stuff and mixing chemicals and all that kind of stuff that you kind of think about when you think about research. We don't have to be involved in the research project. We don't have to be involved in the studies. However, our practice does have to display that we are using best practices, and we're getting those best practices from research. So we have to be able to locate these research publications and apply the best practice to the care that we do. So that's how every nurse is involved, at least to the point of looking for on our databases the research that's been published on a particular care practice or something like that. The other areas is we can identify problems in our practice. That doesn't mean we have to conduct the research. We could conduct a quality improvement project. When we identify a problem, we bring the problem to a group of people on a quality improvement panel. We collect all the information about what's going on in current research. We disseminate or we share the findings. We can be involved in conducting the research. We can be involved in critiquing the research findings that are being published. So just because a research finding has been published does not mean that it is appropriate to change our practice. We have to critique the research. We have to be knowledgeable enough to be able to critique their research, to look at how they conducted the research, if their findings can be applied to the general population or to the group we're looking at. And then if we've done all that and have determined that, yes, this is good practice, we need to implement this, then we can change we can be part of the process of changing the policies and procedures and the standards of care in our facilities that we work at, okay? So when we talk about evidence-based practice, it is using what is available, current research that is available on the topic that we're looking for. It has to be current. And so when we talk about current, we're talking about within the past 5 years. And if there's been nothing that's been published or researched in the last 5 years, yes, we are going to fall back on what the best available research is out there. So those are things to keep in mind. The QSIN focus does the quality, safety, and education of nurses does fall back and say that we do need to know how to critique research and differentiate it from opinion or actually evidence as what could be possible. Now, when we look in our professional journals, research articles that are published in our professional journals, like for instance, the professional journals for obstetric care, the research that goes in there before it's published, there is a panel well, JOGN is the name of the nursing journal for obstetrics. It stands for Journal of Obstetrics and Gynecological and Neonatal Nursing, I think is what JOGN stands for. Anyways, there is a panel in that organization that does review and critique the research publications before they put them in their journals. So if they're in a journal, they're probably legitimate, but that still does not take the responsibility off us as nurses to review those articles before we implement them into our practice. An example of some evidence-based practice is hand hygiene, and you hear this a lot about hand hygiene, and it's very important. And so the Centers of Disease and Control and Prevention, they conducted evidence-based research on hand hygiene, how that does help us cut down on the spread of infection to other patients, other healthcare workers, and ourselves. So they have made recommendations on proper hand hygiene, and that's what we teach you in nursing school. Now, when we do conduct evidence-based research, we follow these steps. Like I had mentioned earlier, we do assess for a problem. So what is the problem that we're noticing? And it could be anything from, hand hygiene to proper care of a central line, to decrease infection, proper pre-surgical care to decrease infection rates, proper care to decrease the risk of developing a deep vein thrombosis. There's all kinds of problems, all kinds of different problems, but we determine the problem based on the outcomes that we're seeing with our patients. And then once we've determined what the problem is we want to focus on, then we have to kind of develop a question in order to narrow our literature review. And then so we do this literature review, we search the evidence that has been presented in our databases and in our journals, and we evaluate those. Like I said, we critique those. And then if we've determined that this is good practice, then we develop a plan to implement this practice into our care plans. And then, so we develop this plan and then we implement it. And then after a period of time, according to the plan that we've devised, we then will reevaluate. Did this actually fix our problem? Or did it make it worse? Or did it not even change? And so should we go a different route and things like that. So that's the official way of conducting evidence-based research. Now for each one of these steps, I have broken it down into, so for each one of these steps here, I have broken it down for you, defining it more. So you can look over these. I'm not going to read these slides to you, but basically what I've explained is spelled out in these next slides. So assessing our problem. The next phase, which I'm going to go over a little more in detail, is developing a question. And there is a format for developing a question. And you can use the PICO mnemonic. And what that stands for is when developing a question, we have to identify P, our patient, or our population, or our problem. Okay? The I stands for what intervention are we doing? Or what intervention do we want to do? And then we compare it with either one, the intervention that we're doing, or the intervention that we want to do. And then O describes the outcome. What is the outcome that we are getting from both of these interventions? How do they compare? Okay? And then the third phase, again, is searching our databases. And so what I want to review with here, what are those databases? So there's several different categories in which we can use. A general category of databases are these examples: UpToDate, StatRegs, and MD Consult. They're all web-based databases that you have to be a member of or subscribe to, which is costly. Now, the hospitals do provide access to up-to-date. So when we start OB next semester, you will be doing a patient education project, and you will need to utilize one of or all of these different database resources. And Community Medical Center does have access to up-to-date, and we can access that at the facility of Community Medical Center. And so I'll be showing you how to do that. And this up-to-date resource is huge, very huge. Like if you were to research preeclampsia, for example, that's an obstetrical problem, and you would get 20, 30 pages worth of information if you printed this out, printed out the whole document related to preeclampsia. So sometimes it's looking at a resource and using some of the data or all of the data from that particular resource. Now, filtered resources do provide very reliable evidence on treatment and evidence-based practice. And they actually provide systematic reviews of the literature that's been conducted in that field. So, for instance, if I wanted to research a problem in obstetrics, I could go to these, let's see, Cochrane. I'm trying to remember if the university has Cochrane reviews, and I'm not really sure if they do. But when you're a student or an employee of a company that has access to these databases, then they pay the price for you. If you wanted to research on these yourself privately, then it's a huge cost. And so you could find a lot of information on obstetrics, and you could click in and search for everything related to preterm labor or something like that. So they all kind of set up the same. Unfiltered resources, then you can find what there's another place where you can find research publications and systematic reviews. A systematic review is someone is doing all the legwork for you. They're reviewing all the literature on that particular topic, and then they're writing an article about all the different reviews that they have looked over and giving their professional interpretation of those publications. So Medline is one, PubMed, PsycInfo, but CINAHL, Cumulative Index to Nursing and Allied Health Literature, is a humongous database, not only for nursing, but for health and psych and all kinds of stuff. So I know the university does have this database, which you guys can access for free. And then, of course, professional journals. You can go straight to the source of a professional journal. However, if you were doing a search for articles in the Joggin Journal, you would not be able to access that article unless you paid. Again, you paid for that journal in some way, shape, or form. And because of my membership with my professional organization in obstetrics, which is called AWON, the Association for Women's Health, Obstetrics, and Neonatal Nursing, they supply, because I pay my membership fee to that organization, they supply me with access to these obstetrical journals. So I can look in the journal myself, as opposed to looking at someone else's systematic review. Okay. The other way that we can find evidence-based practice is the clinical guidelines. So I always use obstetrics as my example, because that's what I deal with. So AWON does publish clinical practice standards for any type of topic related to OB. And so you can, whichever specialty you're in, you can access those. Remember, we have to evaluate the research that we're looking at. Is it valid? Does it apply? Is there any weaknesses in the research that they conducted that might make their results not applicable? So here's all your validity questions. One of them I wanted to point out is I mean, these are all the criteria for the research. Let me see if it's on the next slide. So when you're looking at research, one of the things when you're appraising a research article, one of the validity things that you need to determine is if a pharmaceutical company is researching a drug that they are manufacturing, there's bias in that. They are going to typically show you the results that promote the drug that they are manufacturing. So there can be some bias there. So you've got to be careful when you are, for one of those reasons, you've got to be careful when you're evaluating the validity of research. So when they publish their results, is it significant to the patient population? Is it significant to the problem? Can you truly determine whether the treatment does affect the outcome or does it not? External validity, you have to analyze whether there is external validity, and that has to do with their quantitative and qualitative studies. Quantitative studies, did they use, was their population large enough to generalize the results, or was it just a small population and therefore may not be able to be applied to a larger group of people? Qualitative studies, they do frequently have small numbers, but they don't get quantitative data. They get qualitative data, and so can that be applied to the population? The fourth phase, of course, is our plan to change our practice. The fifth phase is implementing that change, and then the sixth phase is evaluating, yes, did it help, did it not help, things like that. So when you do your evidence-based practice, you will be searching literature, so please do not use some of the databases that are listed in these slides. Do not use Google. Be careful with most of your .orgs are good resources, but just be careful with those. Make sure that they are legitimate organizations. .govs, you can pretty much count on being legitimate sources. Don't use blogs. Be careful with company websites that are promoting their company philosophy or opinions. And so just try to focus on the resources for your project that I have listed here. Okay? All right. Chapter 14. Health literacy and patient education. So a big part of nursing is patient education. I always say that there's rarely a time that you walk into a patient's room and you do not provide some sort of education. It might not be a formal deal where you sit down with charts and pamphlets and blackboards and whiteboards and things like that. It may just be simple. I have your medication today. This is what the doctor prescribed for you. This is what the medication is for. This is the outcome that we should achieve by giving this medication. These are the side effects that are possible. So every time we walk into a patient's room, we're providing some sort of education. When you go in and say, hey, your doctor ordered an NG tube, then you educate the patient about what the NG tube is for, how the procedure is going to be conducted, what the patient can expect to feel for this procedure, what all the things related to. You don't just walk in and just do stuff to people. You explain, and that is patient education. But we also have to remember when we're giving patient education about the patient's health literacy, which could be extremely different from their actual intellectual literacy. Okay, so we're going to review those things. So here are the outcomes that you need to achieve from reading and studying this chapter. All right, so what is health literacy? So the American Medical Association has officially defined it as the ability to obtain, process, and understand basic information and services that we are providing in relation to a patient's health. Now, low literacy refers to individuals unable to comprehend health-related information or instructions. If they can't comprehend, then they can't make informed decisions, they can't give informed consent, they can't follow discharge instructions, and so it does contribute to hospital readmissions, which cost lots of money. And we can help this problem before the patient leaves our care. So we have to evaluate their health literacy. And do not assume that just because the patient has master's degrees or a college degree or even a PhD that they understand basic health information. So it's our responsibility as nurses not only to present the information to the patients and their families, but to ensure that they do comprehend what we're saying. And if I ask you, do you understand what I'm saying? And you tell me yes, is that indeed my way of confirming that the patient understands? Absolutely not, but we do it all the time. So we have to find ways in order to confirm the patient's understanding of the health information we're getting them. Also, we can give a patient an education about medication or a treatment or a discharge instruction, and if we are not taking into account their cultural background and their social economic background, and of course their age and general literacy, then we're missing the boat entirely. Cultural backgrounds may have a very difficult time understanding our medicine and our procedures and why we do them and the importance of them. If they don't understand that, then they might not follow the instructions or feel that it's important. Someone from a low socioeconomic background may not be able to afford or be able to follow through with the care that they're supposed to be doing at home because financially they can't meet those obligations. And then, of course, people at different ages, we have to make sure that we're giving the education according to their developmental level, okay? So we have to make sure we're giving the information in ways in which they can understand it, and then also confirming that they do understand. And oops, did I go the wrong way? And so just asking a patient, do you understand, is not okay. We need to actually have the patient tell us, what is the correct way for you to take this medication? Do you know how to take care of your wound dressing? Do you know how to test your blood sugar? Show me, show me, show me, show me. Tell me, tell me, tell me. That is the best way to confirm. And then also, once we've confirmed that they do understand, are you able to do these things? Do you have the means to get your wound care supplies? Do I need to find some sort of resource for you? That you can access to get these supplies? Things like that. Do you have the ability to go to the pharmacy and get your medications? Those kind of things, okay? So again, it's nurses' primary responsibility to educate our patients, to give instructions that they can understand. We're providing disease prevention education, promoting health. We're providing education on treatment instructions, clarifying information that they've misunderstood, and coping with the limitations that the patient has. Like I said, do you have the ability to do this? Can you physically inject yourself? Show me. Can you physically get to the pharmacy to get your medications? And then all healthcare providers have the responsibility of providing instructions. So physical therapy comes in and teaches your patient the exercises they need to do after they've had their hip replacement at home. We need to know that education that they're providing, because we as nurses need to confirm that they understood the physical therapy instructions that they received, or the nutritionist instructions that they've received. Okay, so we got to know everybody's job. That's why we're so amazing. We're nurses. We rock. Now, when we are giving instructions to our patients, we have got to be careful. Like, we're so used to talking to healthcare providers and using the abbreviations and the medical terms that we're comfortable with. That's what we're supposed to do when we're talking to each other, to other healthcare providers. But we can't use those terms with our patients. Here's your pain medication. You just need to take it PRN. Okay? They don't understand what PRN means. And if we use medical terms, they might not understand medical terms. So we need to make sure that we're using terms that the patient can understand. This is kind of similar to evidence-based practice. So a lot of patients educate themselves, and that's great, and that's terrible, because some of the resources that they're using to get education about their health condition or their health promotion practices may not be legitimate sources. And I'm going to use the example of vaccinations. There's a lot of people out there that do a lot of their own research about vaccinations. And a lot of people have believe when they read this .com or .org information about vaccinations, this could have been created by, it could have been created by healthcare workers, but it could have been created by well-known or professional people that are not necessarily healthcare people, that have had personal experiences, and they're trying to get the word out. So I can't remember the famous actress, or was it a singer? See, I don't even remember. Had this big .org, I think, website about vaccinations, and she was promoting her opinion, and she was gathering all kinds of evidence and resources that backed her opinion, and that's all she presented to the public. And so, of course, some woman who's raising 2 children may have an excellent educational background, respects this famous actor person, and believes what she is publishing. And then she decides that in her personal life, she is not going to vaccinate her children. And so we need to evaluate the education or the resources our patients are using. And that can be a very, that can be very tricky waters there, because they have also learned to be very strong in advocating their opinion and not to let the healthcare community push their agenda. And so they can be very argumentative with us about their decisions. So we need to be very careful on how we approach these people, and just very matter-of-factly confront their resources. Like, we need to tell them, what resources, ask them, I'm interested in the resources that you use to come to this conclusion. And I'm interested in how you validated the accuracy of what you have learned. And although the information that they have given you, it presents their personal opinion, and they have supplied you with all their resources, which also back their opinion. But there's all these other resources that do prevent another side that you should possibly compare. I would really like to provide you with a bunch of science-based research and let you evaluate your findings with these findings to make your decision. Is that okay? Can I provide you with that information? And sometimes they're like, nope, absolutely. I do not want to hear what you have to say. I'm very secure in my decision. They may be like that, or they may be, yes, I will look at what you have available and I will make my decision from there. And hopefully they do that, and then they're able to see, yes, this might not be as valid as I had originally thought. So, okay. Factors affecting health literacy. So there's all kinds of diversity considerations. So, of course, when we educate children, we need to educate them according to their specific age. So do not think that just because it's a child that you should not involve them in the education of their condition. That is not okay. Of course, you'll be doing it with the parents, but the children do need to be involved. And we do need to present it to the children in ways in which they can understand. So we may just be using pictures for these children, especially if they're very young. You know, if they're school-aged, we can provide simple explanations. But then as they get older, we can present more technical information as they become high school and children. We do need to make sure that we do not assume that adults know how to read. So if we're handing people information and they don't know how to read it, then it's not helpful. They're not going to get anything out of it, okay? Culture and religion does affect what people will accept for care. So we need to take that into consideration. If we recommend a certain diet to a culture that does not eat those kind of foods because their culture doesn't allow that, then that's not going to be helpful. We need to find another way for these patients, okay? Use professional non-family members as interpreters. I cannot express that enough. And we don't do that 100% of the time in healthcare. It's easier just to ask one of the family members who knows how to speak English to interpret for us, but that is a very dangerous and slippery thing to do. So we have found a lot of communication errors doing that based on that language's ability to have words for our English words, okay? So we have got to use professional medical interpreters because when we talk about obstetrical things and we talk about the perineum or the breasts or the uterus, does the culture have words for that? Well, the professional medical interpreters will have a way to get that term across to the patient. So we must always use professional interpreters, not family members. We can photos and videos are great for people that have other languages to use for our education. Now, people with disabilities, we have to be sure that we are giving them information. Like if a patient has a hearing loss, then we want to make sure that we're not giving them any videos or anything they need to listen to. If a patient has a visual loss, then we might want to give them things they can listen to or find the information in Braille if they know how to read Braille. So we've got to make sure, and people with learning disabilities, we've got to somehow figure out a way, very simple ways to get this information across with people with learning disabilities. And it can be done, okay? So I've already talked about age and developmental ways to provide educations. The role, so how does what we're teaching them affect the role in their family, the role and their work life, so we need to make sure we accommodate for those things. When we're educating someone, we need to make sure that we're doing it in a setting in which they can receive the information. So if a patient is in pain, they're not going to receive the information. If the patient has nausea and vomiting, they're not going to receive the information. Are we doing this in a quiet environment without interruptions to help the patient? That will cause the patient to lose their train of thought. So we need to be mindful of that. I've already talked about economic resources. Are the patients able to follow through financially with the care that or with the treatment that we're advising them to do on discharge? Do we need to involve social services? Social services will be able to find resources for this person within the community. Okay. And then, of course, we got to provide evidence-based education that's unbiased and accurate, but we also need to consider the patient's right to accept or reject what we're telling them. So, for instance, I like to use you can think of a diabetic patient that has to cut out sugary foods, that is addicted to Coca-Cola. So I'm not going to give up Coca-Cola. Okay. So can we try doing Diet Coca-Cola or a smoker? You need to quit smoking or you're going to die tomorrow. No, well, they're not going to die tomorrow. But you know what I'm saying? Will you quit smoking? No, absolutely not. I am not going to quit smoking. I've been smoking all my life. It's going to kill me whether I quit today or never quit. So I'm not going to do it. I said, okay, well, you do work outside. It's, you do physical work and you do have a hard time keeping up with the physical demands of your work. So how about we cut down on your smoking to give your lungs more of ability to have pure oxygen instead of polluted oxygen that you breathe in. Can we cut down on smoking? Yeah, I'd consider cutting down because I do need to work and it's really hard for me. So I will consider a plan to cut down smoking. That is better than nothing. Yes, they're still smoking, but maybe if we get them to cut down and they do see the improvement in their ability to function, maybe they will come back and say, hey, I would like to try smoking. Man, I can really outwork those young bucks at work now because I don't smoke so much. So I'd really like to take this all the way to the top and completely quit smoking. So let's work with our patients. So we've already talked about this in the previous chapter about using research, clinical practice, standards of care type of things to provide for our patients. So carry out assessment on your patient's health literacy and educational needs. So we need to ask those questions. Who will be taking care of you? I need to involve those people in the education. What do you already know about this? Tell me what you already know, okay? What's your preferred language, of course? Do you have internet access? What's the highest grade level you completed? We do ask that as just a general question in our admission process. But I don't like to rely on this as confirmation of their ability to understand, okay? So I don't rely on this so much. Can you read the local newspaper, or can you read? Or do you like to read? How do you like to get your education? Do you prefer that I just explain things to you? Do you prefer that I let you read these things and then we go over them later? Do you prefer to watch a video? How do you like to learn? What do you hope to learn from our teaching sessions? That's a good question, but I do want to have you exercise caution with this. If they say, well, all I want to learn about my diabetes is how to give my injections, and all we teach them is how to give them their injections, and we don't make sure they know how to test their blood sugar accurately, they don't know when to give or when to check their blood sugars, before or after the meal, they don't know proper diet, then we're limiting the education we give them and not providing the full thing that is important. And the same thing with the question, what information do you feel is most important? They may not know what's most important. They may feel what they think is most important, but we need to provide a thorough education. Have you ever had education on this subject before? If so, ask for details. If they say yes, the nurse before you, she told me all about how to breastfeed my baby. And then I will say, well, tell me about that. How do you breastfeed your baby? Okay. So I don't just take it that the nurse before told her everything. I don't take it that she understood everything. I have the patient explain to me what they've learned, and then I fill in the gaps from there. How do you feel you learn best? I've already talked about that. Do you have difficulty with hearing and vision? We need to know that. Are you having any pain or discomfort or nausea or vomiting? Or are you anxious? Are you worried about anything? We need to know those. So, because if they're having any problems in those areas, then their ability to comprehend what we're saying is going to be very limited. Ways that we can tell from our patients' comments or actions that they do not have good enough health literacy, even though they may have told us, yes, I can read. Well, the patient asks us to read the information for them, or they might say, I left my glasses at home. That might indicate, no, they can't read really well, and they were too embarrassed to tell us they can't read. All right. Another way we can tell is if we actually have them fill out forms and they don't fill them out completely, or they fill them out inaccurately, they may not have been able to read that question correctly. If they frequently miss appointments, if they do not comply with the medication regimens, you have a patient that comes back to the ER after they were in the ER for a UTI, and they got medications for the UTI, and they went home with a prescription or with the medications, and they didn't take them correctly because they didn't understand. They come back in, and now they have a raging pyelonephritis or kidney infection. And then we find out that they weren't taking their medications. And it may have been because they didn't understand, or they couldn't read the instructions. And the same thing with lab tests or consults. They didn't understand the instructions, so they didn't follow through with what they were supposed to do. Here are some nursing diagnoses that you can use for your health literacy care plan. Here are some patient goals that you can use. Patient will demonstrate. Patient will verbalize. Great. Patient will list. Let me go back to nursing diagnosis. Let me... okay. So anyways, please look over these. All right. So this again just says a lot of members of the team may be giving education to our patient, and we just really need to make sure they understand what everyone has told them. We've talked about this, the environment that we are in when we're giving the education. We need to make sure our patients are comfortable, that a lot of times the patients are with us for a short period of time, and we have so much education to give them. So if we do everything in one setting, they'll probably only retain 10% of what we told them. So I'd like to take advantage of every time I walk in the room, I just do a little bit at a time, and try to get it all in that way. And plus, also, we do these follow-up phone calls a lot after the patient's discharge from either outpatient or inpatient stay. And we do these discharges 24 to 36 hours after they've left the hospital to make sure that indeed they did understand their discharge instructions. We find out how they're doing. Are they taking their medications correctly? Are they doing their care correctly? Things like that. Using basic terminology, using familiar words, using handouts, and whatever we can use that the patient finds helpful for their learning. Repetition is great. Demonstration is great. We go in, we teach the patient how to do their insulin injection. We do it once for them, and then the next time we go in and we try to get the patient to do the remainder of their injections, so that by the time they're ready to leave, we are comfortable that they know how to do it. Okay. We evaluate by seeing the demonstration. We evaluate by having the patient repeat back to us the instructions. that they've received. Of course, we document all the education that we've given in the healthcare record. One is to provide evidence that we did teach this patient how to do the thing that they did. It does provide evidence that the patient did reiterate what we told them or demonstrated correctly what we showed them, but it also allows for the next nurse that comes on to review our documentation, to know what was presented, to know what the patient did, so that then she can focus on something else for the patient. Okay. Again, we've got to continue to review. We don't just present at one time. We continue to review over the course of their stay, providing adequate time for the patient to ask us questions and to demonstrate. Okay, so that's patient education. I do want to provide you with some examples from my practice. We had a patient years ago that had 2 master's degrees, and I can't remember what they were in, but they were some sort of science, biology, chemistry, I don't know, but she had 2 separate master's degrees. Very educated woman. So she did all her research on group beta strep, flora in a pregnant woman. And so this is an OB thing, and I don't want to teach you about OB right now, but just some brief background education. Group beta strep bacteria, it can be a flora that a lot of women carry around in their vaginal, anal area, and it does not cause them any sickness or problems, and it does not need to be treated. Okay. However, if they give birth vaginally, that baby passes through that vaginal canal and contracts that group beta strep bacteria. That baby can develop an overwhelming and fatal septic infection. So we treat women who have a positive group beta strep bacteria with antibiotics while they're in labor. We don't treat the woman to clear her of that bacteria. We treat the woman so that the baby is being treated prophylactically. So when the baby passes through that vaginal canal full of group beta strep bacteria, the baby will not convert to an infection. Well, this educated woman with 2 master's degrees in the science refused that antibiotic because her research that she did promoted that it has no bearing on the outcome for the baby. And so she refused to allow us to give her antibiotics. So we were like, okay, so now we're going to have to, we couldn't give her antibiotics despite our education on evidence-based research. And so we knew that we were going to have to monitor this baby for possibility of conversion to a septic infection. So we monitored this baby after birth, and indeed this baby did contract a septic infection and had to be admitted to a NICU. And the treatment recommendation is ampicillin and gentamicin to treat that infection. And she refused to allow us to give the baby gentamicin. So you only let us give the baby ampicillin. But it wasn't a big enough antibiotic to kill the infection. So the baby's stay was prolonged, and then eventually the woman did allow us to give the gentamicin, and then we cured the baby of the infection. But here's what happened to the baby is she was admitted to the ICU, or the NICU, the neonatal intensive care unit. We had to start an IV on her. In order to gain IV access, this baby was poked 7 times, okay? And the baby was sick and probably felt like crap. We had to take blood samples like every 8 hours or 12 hours? I don't remember, but that was still pretty often. The baby was a patient for 10 whole days. And I was so angry at this woman because when she came into the NICU, she was really focused on the baby's ID badge, a bracelet band that was on her ankle, and felt like it was too tight and causing her pain, and made me take it off and put on a new one. Well, the process to do that was really laborious because the ID band that was on the patient belonged to a 4-part ID band with pre-printed numbers on them. The baby had 2 of them, one on the ankle, one on the wrist. The mother had one, the father had one, and then there was paperwork and documentation in the chart about this band and the numbers that were printed on them. And that was our official way of identifying this baby and identifying the correct parents. And then so the process to change that band was all that paperwork had to be redone, bands had to be done, mom and dad had to get new bands, baby had to get new bands. But it wasn't so much that irritated me. What irritated me is I cannot believe that you allowed this to happen to your baby. All this pain your baby has been suffering from the IV pokes, the blood sticks, the venipuncture sticks for blood draws, the way how crappy your baby is feeling right now, how sick and crappy your baby is feeling right now. You caused that. And you were worried about this stupid little band, which wasn't hurting the baby's ankle at all. Okay. So, anyways, my whole point about that is do not assume because someone has master's degrees that they know what the heck they're talking about. And this is a perfect example of her research. And everything she was gathering was focusing on how this was not a legitimate care practice. It was just the medical community to cover their butt, and it was not needed. And so she would hear nothing from us. When we presented our evidence to this very educated, scientifically educated person, she would not receive our education. And so that's my point. Okay. So anyways, all right, let's finish up with bowel elimination. Lovely topic. Here are your learning outcomes for the chapter. Please review these and know how you will be expected to learn. So we're going to, and then of course, make sure you review the normal structure and function of the GI tract. And now we're going to talk about possible alterations in bowel elimination. So we all know about diarrhea, what diarrhea is, and most commonly caused by C. diff or Clostridium difficile. But for rednecks like me, we just like to say the easy word, which is C. diff. It's a bacteria that causes diarrhea. It could be such severe diarrhea that it indeed threatens the patient's life. Hold on. And it's very infectious. So a patient who does have a C. diff infection, they will be on contact precautions. Okay. We learned about incontinence when we learned about urine. Someone can be incontinent of urine, and they can also be incontinent of stool or flatus or gaseous discharge or farts. Whatever word your patient uses, use those. So, when you use the word fart, everybody wants to laugh, and it's so funny. And it can be uncomfortable in coming out of a professional's mouth. However, if your patient doesn't know what flatus is, then don't use that word, okay? Because they don't understand flatus. They understand fart. So you can say, are you having any flatus? We always assess an OB patient after her delivery, and we say, are you passing gas yet? That seems pretty pretty normal word to say that a patient can understand. But they may confuse that with burping. Are you passing gas? Are you burping? Well, they may not realize that passing gas means having flatus. And then, so are you having any flatus? Well, I don't know. What is flatus? Did they bring it to me on my dinner tray? I don't know. What's flatus? I don't know if I've had it. Is it a pill? So we could say no. Flatus means farting. Are you farting? Oh yeah, I'm farting. Okay. Or, oh no, I'm not farting. Constipation is another alteration, of course, where we're having either infrequent or no bowel movements or difficulty having a bowel movement. Now, that's fewer than 3 bowel movements per week. Okay. So just like the normal temperature is 98.6, normal for someone might be 97.6. Normal for someone else might be 99.6. Normal for someone may be a bowel movement every day. Normal for someone may be a bowel movement every 4 days. They don't feel constipated. They're able to eat. They're not having any nausea. So yes, every 4 days is fine for that person, but every 4 days might not be fine for me. Now, if someone says, okay, yeah, I normally don't have a bowel movement, but once every 2 or 3 days, I would say to them, then that would prompt questions as a nurse. Okay, are they uncomfortable and hard to pass? No, they're just fine. Do you have any strong cramping or uncomfortableness in your belly because you're only going every 2 days? I can't remember how many days I said. No, I don't have any problems at all. Are you able to eat an adequate diet? And then we need to define what's adequate for that person. And they say, yeah. And then I'll say, do you have any periods of nausea and vomiting? And they'll say no. How does that relate to constipation? Well, if a patient is constipated and they're getting back, if their GI tract or their bowel pipes are getting backed up and full of stool, then there will be a point at which they cannot eat because they are so full of stool. Or there will come a point that they feel nauseated and they can't eat because of their constipation. So those need to be questions that you ask when you ask a patient, what is your normal bowel schedule? How often do you go? Do you have to strain? And are your feces hard to pass because you only go once every 3 days? Okay. Now, when patients do strain, though, we need to be careful. Is this a patient that has any type of brain problem or any type of cardiac problem or any type of hemorrhoid problem? Because straining increases internal pressures in the body, and if they already have a problem with something within their brain, if they already have problem with pressure within their brain, then bearing down and straining for a bowel movement may increase that pressure in their brain and cause a problem. Same thing with their heart. If they have heart problems, the straining and the bearing down may exacerbate their heart problems. And of course, if they have hemorrhoids and they're straining, then they may worsen their hemorrhoids, okay? All right, the Valsalva maneuver occurs when a person holds their breath while bearing down, okay, and that causes a rise in their blood pressure, and that's why we call it, we want to know about their cardiac status and things like that. If a patient has an impaction, so the stool that's in their rectum or colon is so hard, it's like a brick in there and there's no way they can pass it. And if that indeed is the case, then I'm sorry, nurses, we do need to go in there and possibly dig that out. Now, first, we may want to try some sort of enema. We're going to talk about those in a minute. We may want to try some sort of enema that softens up that stool for the patient to have the ability to pass it. But if we've tried those kind of things, and they cannot pass that stool, yes, indeed, we will need to digitally go in there and remove that stool. And we've already talked about flatus, passing gas or farting. It's a normal bodily function. But if they're not able to pass gas and they're building up this gas in their intestines, then it will cause abdominal distension and pain, depending on the degree. And then so a lot of times in our assessments of patients, especially patients who've had any type of abdominal surgery, when we palpate that abdomen, of course, you're going to listen for bowel sounds and you're going to hear all these bowel sounds in there, but the patient is unable to pass the gas. And then you're going to palpate their belly and it's like a rubber ball, and it can be hard enough that maybe it's not this really soft rubber ball, but it's not this squishy fatty ball. It's this buoyant boing, 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 like a balloon, like when you blow up a balloon and you squish the balloon and how it boings, okay? That's what their belly will feel like. And so you need to intervene for your patient at that point. And we'll talk about the interventions that we could possibly do for these people. You may have people that already have in place bowel diversion devices. Bowel diversion devices are surgical, it's a surgical procedure that we do, that we put some sort of appliance either internally on a patient or externally on a patient that acts as their rectum, okay, or how they pass their feces. And so when we're talking about bowel diversion devices, when we use the term ostomy, ostomy basically can be anywhere in the body. Ostomy is just a surgically created opening from an organ. So it can be from the bowel, it can be from the stomach, it can be from the bladder, it can be from the respiratory tract, it can be anywhere. It is a surgical opening to the outside of the body from an organ. Okay, an ileostomy is a surgical opening specifically to the small intestine. The stoma is the actual opening, the actual site on their body. That is called the stoma. Okay. So when we use the term colostomy, that is the surgically created opening from the colon or the large intestine. There's several different kinds of colostomies. It just depends on what part of the colon that opening is created from. So if it's an ascending colostomy, then it's from the ascending part of the colon, that first part of the colon on the right side of the body that goes up. Okay. Now the stool that comes from the ascending colon is a liquidy stool. Okay. It's not as formed because, you know, when chyme, or the stuff that goes from the small intestines to the large intestines, you know, it's just basically this liquidy mush stuff. And as more water or fluid is absorbed from that matter, then as the stool progresses through the colon, it gets more solid or more formed. The colostomy that goes on the transverse colon, the part that goes horizontally across the abdomen, those are called transverse colostomies. And the matter that is drained from these sites is more formed than the ascending. Okay, and then we have I'm sorry, I will go back to that. Okay, let's jump to this side. The sigmoid or descending colons, so those descending colostomies, those colostomies are coming from the descending colon, the one on the left side of the body. They are the most common type, and the matter from there is a more solid matter. Okay, so let's go back to this. So we have all these colostomies depending on where they are on the colon, and then, or the large intestine, and then they can be different also in their formation. So this is a double barrel colostomy. Two ends of the bowel are open and brought through the abdominal wall. So you have two distinct stoma sites. Remember, stoma is the actual site. Okay, it is a colostomy because it's from the intestine to the outside of the body, but the actual site is called a stoma, and you will have two distinct stomas. Okay, now the proximal end of the stoma is the functional end. That's the proximal, meaning at the beginning of closer to the beginning of the colon. That will be the one that drains stool. Okay, the non-functional stoma site is because there's no stool coming from that site. That's the distal end. You may have some mucus or stuff like that draining from that site, but there's no stool being generated or going through that distal site. Okay. All right. Now then we'll down here at the bottom of this slide, there's the loop colostomy. They are temporary colostomies where they pull the bowel through the abdomen. They make a little incision. There's still a portion of the colon that is connected, but the stoma site is not from severed colon, okay? And so they will use this. It's a temporary deal. They'll use this in an emergency situation. So here's just a picture of some of the different colostomies according to where they are on the large intestine. So this is your ascending, this is your, over here is your transverse, and this one does have a double barrel. This one is your descending, and this one's your sigmoid, okay? So it is where they are in the bowel, okay? Now, an ileostomy is a colostomy that comes from right there from the ileum, okay? It's from the small intestine. They can be temporary or permanent, and it's because they've removed all of or part of the colon. And these are very liquid matter that's drained from there. Now, because that drainage does still contain a lot of digestive enzymes, which can do a lot of damage to the skin. So the ileostomy care is very important to prevent skin breakdown. So we'll be learning that this week. Here's a picture of an ileostomy, okay? All right. Now, there are things called pouches that these patients may have. The ileoanal pouch, and these are technically they're not an ostomy. It's a pouch inside the body that collects the stool instead of a pouch being outside of the body, okay? And there's different versions of this, and there's the cock pouch. This is also on the inside of the body and collects the stool matter, and then, you know, at certain times during the day, both of these can be drained. Here's a picture of one, okay? So this is an ileoanal pouch or reservoir. So here's the ileum, it's connected to this pouch, and then here's the sphincter, anal sphincter, okay? So these people may be able to defecate or depending on the condition of the sphincter, okay? All right, of course, medications, diet, activity, even emotional issues, psychological factors can all affect the GI tract and have it function in different ways. Psychological factors, habits, pregnancy affects the GI tract, all these kind of things. If people have any type of blocks, anesthesia blocks, it will affect their colon, their defecation, and their peristalsis throughout their small intestines, okay? If a patient has surgery and there's manipulation of the intestines, that can cause loss of peristalsis. If a patient's unable to eat or move after surgery, that can cause a delay in bowel function. And then if a patient has a paralytic ileus because of medication or we've given them food too soon before surgery, after surgery, then their peristalsis can just stop and cause a problem. Now here's the thing. A patient who's had anesthesia, a patient who's had surgery, when their peristalsis slows down or stops temporarily because of those things, then we need to, post-anesthesia and post-surgery, we need to constantly be assessing their bowel sounds and asking, are you passing flatus? If that patient does not have bowel sounds, we do not feed them, okay? Even if they say, I'm hungry, Okay, well, okay, I can give you sips and chips, I can give you Jello, clear liquids type things, but I can't give you food. And then we just keep assessing their bowel sounds, and then when their peristalsis returns, then we can start feeding our patients. But if we feed them too soon, if they start taking too many narcotics, where they stop peristalsis, things like that, then we can cause a big problem for our patient. Okay, so what do we do for assessment? Well, your diversity considerations are, so when a baby is first born, their first stools are called meconium. They're black and tarry, very sticky, hard to clean off a baby. And then as baby starts nursing or taking formula, then their stools will start converting to normal, what we call breastfed stools or formula-fed stools. Formula-fed stools are much more stinky. And they're a little more formed than breastfed stools. Breastfed stools, I describe breastfed stools as someone mixed cottage cheese and Grey Poupon, and that's breast milk stool. Okay. Constipation can be an issue for a lot of children that we need to assess. It can also be a huge problem for older adults. As a matter of fact, my experience has been the older the adult is, the more problems they have with constipation. And that seems to be the whole focus in life. I mean, if you can't have a bowel movement, your whole life sucks. So older adults are always, like, I haven't had a bowel movement today. I'm really freaking out. So, like, we need to make sure these older adults have really good nutrition, because probably the big problem is they don't have adequate fluid intake, they don't have adequate fiber intake, and that does lead to constipation issues. Pretty common in the older adult population. Culture, ethnicity, and religions. So a lot of times, what the problem is here is different cultures and different ethnicities don't talk about bowel movements and how to have good bowel movements and things like that. So these people may end up having lots of problems because they don't seek help for whatever kind of GI problem they have. Patients with disabilities who have limited movement, or patients that have some sort of paraplegia problem or paraplegic, either quadriplegic or paraplegic, they don't have control over their bowels. They don't have the urges to have bowel movements. These people may have devices and things like that. Patients that have disabilities or cognitive disabilities may have problems with incontinence. So we need to assess the patients, how their disability is affecting their GI tract. Older adults, I'm sorry. People with obesity issues have problems with getting to the bathroom, or have GI problems because of their poor diet, because of their weight, and actually putting physical pressure on their GI tract can create problems. They can have incontinent issues. Large people can have problems with standard size toilets or bedside commodes or things like that. So can have all kinds of problems. All right, so we're going to do a full history like we do on everyone. If this patient's coming in with a GI issue, we have more specific questions we're going to ask them than just the general GI history assessment. So we do ask them specific about if they have specific problems with their GI tract, if they've had any surgeries or any traumas, any abdominal infections, any changes in their bowel function or their appetite or their, what they're eating, or if they're having any nausea, vomiting, constipation issues already. Do they have any family history of problems with their GI? We're going to do a thorough, appetite questionnaire on these people. Medications, of course. And then specific bowel questions, rectal pain, itching, do you have any bleeding when you wipe, or when you have a bowel movement, do you have any bleeding? Do you have problems with bloating or gas? Do you have problems with nausea, vomiting, belching, heartburn, all that kind of stuff? If your patient is pregnant, they're at risk for constipation. They're at risk for heartburn. They're at risk for nausea and vomiting. So we need to ask those things about our pregnant patient. The older adult, we know that constipation is a problem. And incontinence can be a problem. These people, they're so stressed out about their bowel movements that these people may be abusing laxatives or ways to get themselves to go to the bathroom when they don't have a diet that produces enough stool to go every day. So we just need to find out about these things. We need to find out, are they eating fiber in their diet? Are they drinking enough fluids? Things like that. Okay. Again, we're going to do a comprehensive history, the whole history, but really focusing on GI, any people with any GI disorders in the family. We're going to absolutely check out our abdomen, check out our patient's mouth. This kind of goes along with the nutrition assessment that we did last week. And then after we've done our observation, then we can, more information about the observation. So have your patient not sitting up if possible. It's hard to tell if we have any masses or bloating if a patient is sitting up. So we would like them to be as flat as possible or just semi-inclined. But definitely going to inspect their abdomen, looking at the shape. Does it look distended? Does it look the same on each side? Is it symmetrical? Do I see any masses? Do I see any bulging? What does their belly button umbilicus look like? Is there any scars? Do they have any stomas or any lesions? Okay, possible terminology you can use for your assessment of the abdomen. It's flat, it's round, it's scaphoid. In other words, it's sunken. It's gravid. That means she's pregnant. It's obese. Ascites is present. It's symmetrical. It's asymmetrical. And you can describe the masses if there's any masses or scarring or anything like that. And then, so after we observed, we auscultate. So we listen in all four quadrants. Are our bowel sounds present? Are they active? I didn't put that on. I didn't put present and active on here, but those are terms that you would use. Bowel sounds present and active. Are they absent? Are bowel sounds absent? You hear no bowel sounds. Are they hypoactive? Yes, I hear bowel sounds, but my gosh, it takes me 20 minutes to hear them. Or not 20 minutes, but they're not as active as they should be. Are they hyperactive? Like I barely even get my stethoscope on their stomach and I can hear bowel sounds. And then we palpate. So when we palpate for organ placement and size. Actually, I don't palpate for organ and placement and size. I don't know that I would know. A primary care provider is probably very good at palpating the stomach, the liver, and the bowels. But when I palpate, if I can feel bowel loops, then that means that they're probably full of stool. But anyways, I can palpate for masses. I can palpate for pain, palpate for the presence of fluid. So instead of filling that balloon up with air and filling that balloon full of gas, put water in that balloon and feel what it feels like. And the more water you have, the firmer that feel is going to be. Is my belly soft? Is it firm? Is it non-tender? Is it tender on palpation, or do I have rebound tenderness? So we already said this. Did I go backwards? I don't think I went backwards. I think this is all new. But anyways, supine position, that's great. Put a pillow behind these because laying in a supine position, flat in a supine position, may put pressure on a person's back if they have bad back problems. So make sure you get a pillow under their knees or have them slightly inclined. We've already talked about inspecting. We've talked about auscultating, starting at the right lower quadrant and proceeding through each of the remaining quadrants. Then we palpate. Yeah, I think I'm going to delete this slide. That seems very redundant. All right, so we've done our physical assessment on our bowels, on our GI tract, all the way from our teeth down to our belly. So we've done that assessment. Now we're going to do some lab tests. We may do stool cultures if we're thinking that we have some sort of parasite. We'll do sensitivity, culture and sensitivity tests to determine what bacteria or parasite we have and what the appropriate treatment is. That's the sensitivity part of a culture and sensitivity. We might do serial stool cultures. We might repeat those stool cultures after treatment has been implemented to see if the treatment has been successful. We may be testing the stool for blood. We can do a bedside testing, a fecal occult testing, where we use put a stool on this little card, and then we put some activator on the card, and if it, I haven't done one of these in a long time. If it turns blue, I think that means there's blood in the stool. I don't remember. But anyways, or we could send it to the lab and they can look under a microscope. Now, if we have blood in the stool, it could be a sign of something really bad, like a malignant growth, or it could be hemorrhoids, or it could be fissures. It can be an infection. It could just be because the patient has ulcerative colitis or Crohn's disease, any number of things. But the higher the bleed is in the GI tract, the different that bleeding is going to look. So if we have blood coming from the upper GI tract, the stomach, or the upper intestines, then as it goes through the GI tract, that blood is going to be broken down just like food is, and that blood is going to look like coffee grounds. It's not going to actually look like blood. The lower in the GI tract, the more blood looks like blood. But if you have, if you see streaks of blood on the toilet tissue, or if you see streaks of blood on stool in the commode, then it's probably from a very low, it's probably from the colon or the rectum or the hemorrhoids, okay? So just those streaks of blood, so the color and the presentation of blood tells us a little bit of where in the GI tract it's coming from. Okay, sorry, that was really hard to get out. Now, after we've done our lab tests, we can also do diagnostic tests. There's umpteen thousand we can do, actually, not umpteen thousand, but anyways, an upper GI series is where we have the patient drink this barium sludge stuff, and then we do an x-ray, and that will help us see the anatomy better of the upper GI tract, the esophagus, the stomach, and the duodenum. So upper GI series includes those anatomical locations. The lower GI series is, instead of drinking a barium solution, we will give a barium enema up through the rectum, and then we'll do the x-ray, and we can see the rectum, the colon, the large intestine, and the lower portion of the small intestine. Okay, so it'll let us see a lot of things in the anatomy of that lower GI portion. Now, we can do an esophagoscopy. That's where we do an endoscopic procedure to view the inside of the esophagus. Basically, we've got a tube with a camera, and we're going down into the esophagus. The gastroscopy is another endoscopic procedure where we're taking the camera down into the stomach, not just the esophagus. A colonoscopy is an endoscopic procedure where we take the camera up through the rectum and visualize the large intestines. Now, when we do this colonoscopy or the gastroscopy, we can do biopsies, samples of tissues, of polyps or tissues, and for analysis. Okay, those endoscopic camera things do have the ability to have this little thing that grabs tissue. Okay, all right. Nursing diagnoses for your patients with GI problems, constipation. You can review these. These will be helpful in your care plans. Remember, don't recreate the wheel. Okay, use your resources. Here is your patient goals. Possible patient goals you can use depending on your patient's problem. So, what interventions are we going to provide with people with problems? Well, depending on their problems. So if you have a patient who's having decreased bowel sounds, they have their peristalsis has been slowed or stopped, we can give warm liquids to those persons. Those will stimulate peristalsis. If we have a patient that has a defecation problem, constipation, we can give them fluid and make sure they have adequate fluid intake, make sure they have adequate fiber in their diet. And then activity is such a huge thing to jumpstart someone's bowels. Okay, so one of the things that we do post anesthesia and post surgery to wake up those bowels and get them functioning again is get those patients up and walking as soon as we can. That will stimulate peristalsis. Okay. We can give laxatives, suppositories, and enemas to stimulate bowel movements. So depending on what their problem is, we will choose one of those options. We give stool softeners a lot to patients who have constipation issues. We give stool softeners almost routinely to patients who have surgeries, especially if they've had some sort of abdominal surgery or within the abdominal region. So C-section patients will get stool softeners because they've had a surgery where we don't want them to strain with their first bowel movement, which could be in a few days as they start eating again and start moving again and start building up stool to pass. We don't want them to strain with that. So we give them stool softeners to soften the stool. And then there is a stool, so Colace is a stool softener we would give. And then we can give a stool softener that does have a little bit of a stimulant in it, which is Senecot. So they get the softener and the stimulant combination. So just whatever your physician thinks is appropriate. If your patient does have incontinent episodes, of course, we're going to do things to protect their skin, a barrier cream. We're going to make sure that we are cleaning them immediately after every incontinent episode. We may be putting them on incontinent pads that help absorb that stuff away from the skin. And then, of course, you're going to be doing frequent skin assessments to make sure that we're not having some sort of breakdown. Preventative screenings for people. Fecal occult blood testing starts at 50 years of age and continues every year to detect any type of possible malignant type of something happening in their GI. And then sigmoid and colonoscopies do begin again at age 50. And then they continue depending on the patient's risk factors or non-risk factors, then they have one every 5 to 10 years. The diet, of course, we're going to advocate for a high fiber diet for people. If a patient has, for constipation issues or just a general healthy diet, if they have diarrhea, then we're going to teach them about bland, small meals, avoiding milk products, spicy foods, gas-producing foods, caffeines until the diarrhea has resolved. We've already talked about constipation. If a patient has a flatulence issue, where they're extremely gassy people, we're going to teach them about avoiding gassy foods, which would be your cabbage, beans, onions, and cauliflower. If patients are on tube feedings, then the proper preparation of their feedings and the proper care of their tubing and their feeding site, whatever that is, whether it's a PEG tube or an NG tube. We're going to keep their tubings clean. Well, we're going to change their tubings every 24 hours. But the containers, like whatever containers we're using, we're going to keep those clean as well. Exercise is an important part of a healthy bowel program, so we might be advocating for some sort of exercise plan for patients, and it could just be as simple as, walking every day for 20 minutes. But exercise, also remember that this also includes your inpatients, and especially who've had surgery and anesthesia, to get them up walking as quickly as possible. And here we go. Encourage them to be out of bed. If they're not able to get out of bed, they can, they can turn, change positions in the bed, do range of motion activities, either passive, so we're helping them, or they can do active range of motion activities. Something is better than nothing. We know that aerobic exercise raises the respiratory and heart rates, and that does stimulate the intestines. So walking every day is also good on digestive function. Now, some people, we may end up having to set up an elimination schedule. That seems, this seems kind of, I don't understand trying to get people to defecate on command, but but that's not so much what it is. It's promoting, especially with patients with incontinence and even constipation issues, having them go to the restroom on regular scheduled times will help train their bowel a little better. Now, if we have people who are unable to walk to the bathroom, or are on some sort of bed rest, ordered bed rest or something like that, and we have to use a bedpan or a bedside commode, this is, it's one thing to urinate in a bedpan, but to have a bowel movement on a bedpan just seems like the worst thing in the world. But remember, there's two different kinds of bedpans. There's the fracture pan and the regular bedpan, and so you'll use the fracture pan with people. I mean, you can use a fracture pan with someone who has not had hip or back fractures, but definitely if they've had some sort of fracture, then you're going to absolutely have to use that fracture pan. And then sit the patient up in the most natural position as possible, and then do not leave them sitting on that bedpan. Make sure you go back and ask if they're finished and get them off that bedpan. Here's a picture of a fracture pan and a regular bedpan. Okay. And here's a picture of a bedside commode. One thing I want to point out about a bedside commode is a lot of times patients use these without having to call for you to come help them. Some, you have to come help them get on the bedside commode. But here's the thing, especially for the patients that are able to get out of bed and get on the bedside commode by themselves, you need to be checking this and making sure they're not sitting in a room that has urine or stool in it all day. Okay? So, and then these buckets, they slide out of, so this one probably slides out of the side. So this bucket will slide out, and then you go empty it and rinse it, and then you slide it back in. Okay? And of course, wearing appropriate protective personnel as needed for whatever situation you're doing. Okay? If you don't have patients with any C. diff type issues and they're on a bedpan, then just using gloves would be sufficient. But be careful when you take that bedpan to the toilet and rinse it out that you don't get splashed in the face. So I'm not saying that you need to then go put goggles and mask on, but just be careful. But if your patient is C. diff, yes, definitely. Okay? There's all kinds of anti-diarrhea medications that we can give for patients who are having problems with this. Cathartics and laxatives for people who have constipation issues. Cathartics induce defecation, real strong effect on the intestines. Laxative have a milder action, but they stimulate a bowel movement. Laxative suppositories, we can give laxatives by mouth, or we could give laxative suppositories, so up through the rectum. when we place a rectal suppository, we need to make sure that, they're not impacted with stool. Like if you give a suppository to someone to stimulate a bowel movement and they have an impaction, that is going to be holy torture to them. Okay. Giving a suppository to help someone pass a brick is not appropriate. Those people require some sort of enema to soften that stool, break it up, and let them pass it, or digital removal. Okay. And then also when we're so not place the suppository right in the stool. It has to be absorbed in the mucosa, and it won't be absorbed in the mucosa if it's shoved up into stool. The other thing is, please lubricate with some KY jelly your suppository when you're giving it. Now, besides a rectal suppository to give to stimulate bowel movements, we can give rectal suppositories that have medication not related to bowel movements. So, like, we can give nausea medication by a suppository. We can give Tylenol by a suppository. And I don't know what all medications we can do that way, but there's a lot of medications that are given to treat other things other than to treat the GI tract. Okay. Enemas. Enemas are liquid solutions that we put in through the rectum. Depending on what we're trying to do, depends on what the type of enema and the volume of the enema that we're giving. Okay. So we can give enemas to relieve constipation. We can give enemas to relieve impactions. We can give enemas that we need to give to do the diagnostic, like the lower GI series, and to initiate a bowel program. Okay, so here's several different types of enemas. The cleansing enema, so it can be a solution of 120 cc's up to 1,000 cc's. It's hypertonic, so go back to your fluid and electrolyte lecture or text and remember what hypertonic means. So hypertonic means that it has a lot more solutes than normal interstitial spaces. So that means that it's going to draw fluid out of those interstitial spaces into the colon, which provides fluid and distension for the feces. Okay. Another type of cleansing enema is the isotonic. So this is same, isotonic is same. So basically, and again, it's 120 to 1,000 cc's. And basically this just works by expansion, stimulating a bowel movement. Oil retention enemas. So it's an oily type of substance, and we want them to retain it. So that means it's smaller volumes, 120 to 150 cc's. We want them to retain it as long as they can, so that it can do its work. And then they will, when they can't retain it anymore, then of course they defecate. But it lubricates the rectum and the colon, and it helps break down the feces. So if they're having an impaction, the feces will absorb that, become softer, break up, and are easier to pass. We can give enemas that are medications, not necessarily just medications for the GI tract, but like I said, we could give, nausea, I guess, is for the GI tract, but we can give Tylenol that helps with pain and febrile problems. But we can give a medication enema that helps with a local or a GI tract infection. A carminative enema, they're very small, 60 to 80 cc's. And this is if your patient is already like distended from a buildup of a gas. And then it's just a small cc. They're already distended. They don't need more distension. They just need to stimulate the bowel, stimulate peristalsis so that they can start passing this gas. Okay. And then return flow enemas, just 1 to 200 cc's. this might be that we're looking for some sort of impaction, or we're just rinsing something out of the colon, and we just flush in, 200 cc's and want it to flush back. Okay. Other interventions that we may need to do is put down an NG tube. You guys are comfortable with the NG tubes now, and why would be using those? We could use it to just decompress the GI tract, keep air out of it. We could administer medications, feedings. We can lavage the stomach. So this would be for patients who've had poisonings. We want to rinse everything out of the stomach. And we can also use a GI tube to cause compression if we have some sort of hemorrhage in the stomach, okay? There's several different types of NG tubes depending on what your purposes are. So large bore tubes are used for, so the drainage ability of the tube is used for decompressing the bowel, removing gastric contents, to doing the lavage. Common types are the Salem sump, and these are brand names, Salem sump or Levine tubes. Okay, so here is a picture of both the Levine and the Salem sump tubes. Now, other interventions is these patients may end up getting a colostomy or an ostomy or some sort of pouch system, and so we need to learn how to manage those appliances, how to drain those appliances, how to take care of their skin, okay? And so once we learn how to manage those, then we need to teach our patients how to manage those. And a big problem with teaching your patients how to manage those is their acceptance of having this. So having a colostomy and ostomy is a huge psychological adjustment. It affects their self-esteem, their body image. It affects, it could affect their sexual health, their relationship. So these people need a lot of just not only teaching of care, but helping them, supporting them, helping them adjust, okay? There are such things as wound care nurses or ostomy nurses. These nurses go around and manage patients in their facilities or in their communities that have these type of things. So that is a specialty if you're so interested. Okay. Now, of course, whatever we do for our patient to treat their problems, of course, we need to document what we've done in the patient's chart, and then we need to document what the patient's response, how they tolerate it, did it work, did it not work. So in our care plan, was our goal met? Was it partially met? If it was partially met, what is our rationale? And do we need to continue the plan of care or change it? Was our goal not met, and what was the rationale for that? And do we need to change our care plan or just give it more time? Okay. All right. So I do have one more thing I want to show you here. So when we were talking about our evidence-based research chapter, I just wanted to provide you with just some examples of some nursing research that's going on. These are just a list. This is not, you're not going to be tested on this, but this is just to show you what kind of, I mean, this is a small sample. There's umpteen thousand examples of nursing research that's going on. So this is just an example. You can just kind of look over this and just kind of get an idea what's going on out there. And if you want to, you can just research yourself. What kind of nursing research is happening today? Okay. So anyways, that's the recorded lecture. Please, write down your questions. Let me know if you have any questions. And I will see you next week.